What if a pill that you're taking to help you go to sleep is actually secretly increasing your risk of dementia, and it's a lot harder for you to get off of that pill because it's addictive. As a quick disclaimer, nothing we're saying here today should be construed as medical advice. Definitely see your own physician or clinician before making any changes to your medications or other treatments. Hello, it's Dr. Josh, and welcome back to Alzheimer's Breakthrough. My next guest, who has over 20 years of experience in mental health, is going to spread the truth and shine the light on this issue. So let me reveal Dr. Teralyn Sell.
The big reveal. Dun, dun, dun. I'm so happy to be here, only because anybody who follows me knows Dr. Josh has been on my show a couple of times, and we have never met in person, so this is the first time.
This is the captured here.
Right here.
Live.
It's so good. And I just want to add in, you said don't take it as medical advice. We are not suggesting anybody get off their medications or any of those things. We're just talking about a little bit of informed consent today. Mm-hmm.
Totally. And so let's actually start with that. How informed consent, do you find that most patients get informed consent before they're started on, let's say, the category of Ativan, Xanax,
SSRIs, SNR. Well, we could shorten this podcast up because the answer to that is no. Okay. Like, no. Most people don't get informed consent, or should I say full informed consent, before starting any type of psychiatric medication. And that's where you get into a lot of trouble, because years down the road is when you start experiencing some negative side effects or potential for long-term health-related issues of the brain that you weren't aware of going into it. And that's what's happening now in our culture today, is that they're really pushing for more informed consent, thankfully. And it's interesting because, well, let's talk about what informed consent is. It's the risks, the benefits, and the alternatives, and it's also the risks and benefit of the alternatives. So it gets pretty deep, and I don't know why we've shied away from that or steered away from that. But, you know, we have so many, what is it now, 1 in 5 women are on an antidepressant. That number is huge, and the majority of them don't know any risk that they're going into.
Or check this out.
Yeah.
2/3 of Americans require and take a pill to help them get to sleep.
2/3?
2/3. It's a huge number.
You're talking about prescription medication or
both,
anything?
Both prescription or non.
You're right.
Something simple over the counter like Benadryl,
right? Which
we now know has long-term issues if you're taking it every night,
right,
to get to sleep.
Well, that's the whole issue, right? So if you smoke once or twice in your life, like if you smoke 2 cigarettes in your whole lifetime, you're probably not going to have health-related issues. But if you smoke, 5, 10 cigarettes or a pack a day for 20, 30 years, the cumulative effect of that is what we're talking about. Everybody knows the cumulative effect of a cigarette, right? Or alcohol. Nobody knows the cumulative effect of psychiatric medication. Particularly, they might know of like antipsychotics, right? Or benzodiazepines, but your traditional SSRIs, which are your traditional depression or anxiety medications that most people are prescribed,
right,
because they are deemed safe, or the word safer,
right?
And I'm like, what does safer mean? Safer than what? Those are not studied for the long term, so we don't have a lot of brain health research on what is happening to your brain after 20, 30 years. And most people on these medications find that they are on them for 10, 20, 30 years because they can't find a safe off-ramp. So that's, again, in today's world, you might see it politically happening. That's what they're really pushing for, is safe off-ramps for people.
Right.
And I believe those conversations of how to get off something need to start the day that you're put on them. Like, what does that look like? How will I know when I'm ready? What it looks like now, what it looked like for me, because I also was on SSRIs years ago, it looked like, well, we'll cross that bridge when we get to it. We will know when we know. Okay. Like, and of course, I'm like, I was in my early 30s when this was going on. And I was like, okay, that sounds good to me, you know?
So when did that bridge come up in your case?
Like, when did I decide to come off of it?
Right. Or when did you have another conversation with your physician? Or
My conversations were frustrating because every time I would bring it up, I was looked at like I needed more, because I would bring it up because I was really feeling like garbage. Because I was on, I'll just back the story up for slightly so the listeners can understand this. I was prescribed an antidepressant for preventative, which isn't a thing, postpartum depression. So I was prescribed in my 3rd trimester of pregnancy with my 2nd child, and which is a whole different conversation in and of itself.
Well, and you're a grandma now, right?
Yeah, I'm a grandma now.
So this was a while ago.
This was a while ago. This
Okay.
was 25 years ago.
Okay.
The prescribing happened then. So a lot of things have changed, but yet they haven't. Otherwise, we still wouldn't be having these conversations the way that we are.
Right.
But over time, I remember feeling worse. I was really numbed out. I was disconnected with my family. And I would express that to my prescriber. Now, keep in mind, postpartum depression doesn't last for 6 years, right?
It shouldn't.
It shouldn't. And I wasn't depressed going in. It was
Right.
preventing depression, but I felt like I wasn't myself. I felt like I was depressed on the medication. So when you express that to your provider, what happens? Well, maybe we should up your dose, right?
Wow. Or start you on something else.
Or start you on something else. Maybe you need a sleep aid. Maybe you need something else. And I kept saying, in my mind, I was like, no, I need to get off of this crap. Like, I need an out, right? But my prescriber wasn't giving me an out. So I did it in all the wrong ways. Nope. Zoom in, right? Nobody do it like this. We moved. And so this was, again, years ago when there wasn't telehealth prescribing available.
Right.
I lost my prescriber. So I literally went cold turkey.
Oh, wow.
And that was the end of my story, yet the beginning of my story, right at the same time. Don't ever go cold turkey on these medications, because the withdrawal is terrible and it's very bad for your brain. So anyway, I did it in all the wrong ways, but that's how I got trapped. And my story is not that dissimilar to the majority of people's stories out there. And now, fast forward, as a middle-aged woman, like, go to the doctor once, being me, in a menopausal woman, and what do they offer you for everything that you complain about? Fatigue. Oh, I was offered a stimulant. I was also offered a sleep aid and another antidepressant in one visit with an endocrinologist, of all things.
Whoa.
'Cause I was there for my thyroid. I knew my thyroid was off. And before doing labs, she goes, well, I can get you a stimulant, an antidepressant, and a sleep aid. And I went,
It's like
what?
going to a bartender.
Yes, exactly. Like a shot of this and a side of that and a chaser of this, please. Yes,
Wow.
You're right. But I was offered a med stack, and this was, I don't know, 6 years ago. This wasn't that long ago. This is who I am now, right? And I literally looked at my prescriber and I was like, no, thank you. And she said something odd. She goes, then why did you come in? And I went, well, for my thyroid,
You're an endocrinologist?
Yes,
Yeah.
why do you think I came? I'd like to know why you think I came in, not for psych meds, right?
Right.
At this point. So it just gets me thinking, like, how many people, I am not unusual. I'm not an outlier here. I am the norm. I am the profile of psychiatric medications, and all I said was, I'm tired a lot and I feel fatigued, and layered on, right? And so it just got me thinking a lot about other people's experiences and my clients' experiences, because when you complain, when you lodge a complaint, you get the hammer, right? So when you're a hammer, everything's a nail. So when you're a prescriber, in psychiatric prescriber, you can prescribe these things. You're a hammer. You're looking for a complaint that you can hammer down a psych med on.
Right.
And to me, that's not scientific. at all. Like, to me, that's hurtful. And you can get just about any psych med you want in today's world just by lodging some complaints, how you feel.
True.
And instead of asking, well, why aren't you sleeping? What's going on? Well, my husband snores like he doesn't. He's walking around here. He does not snore.
Good to hear.
Yeah. Anyway, I want to remain married after this podcast, but anyway, no, it's fine. But nobody asks the questions like, how much caffeine are you drinking in a day? When do you stop drinking your caffeine? Like, do you drink alcohol before bed? What are the things that you're doing during the day that are impacting your sleep, therefore impacting your mood? These questions are just not asked.
Right.
So I just think we need to do a better job of curiosity with people.
100%. And part of that is actually having the time to have meetings like that. Now, you have a PhD in psychotherapy, but it sounds like firsthand you witnessed the challenges of deprescribing, and it sounds like that's turned into one of your specialties.
It has. Like, it was like, what do people call it? I accidentally fell into this, I guess, specialty. So my PhD is in psychology with an addiction studies focus. So oddly, in the state that I live, we had to take psychopharmacology classes to get licensed for addiction work, not for mental health therapy, but for addiction work.
Got it.
Right?
Yeah.
So a lot of therapists don't ever have to formally take psychopharmacology of any sort. They do it on their own. So I had to formally do it, which was great, but it was also short-sighted at the time that I did it, right? Because it was more about classifications and when someone would be prescribed. It definitely wasn't how to deprescribe, but you can take the work of addiction psychotherapy and apply a lot of those to getting someone help off of psychiatric medication, of course, with their own prescriber, right? Or a prescriber that you're collaborating with. I don't deprescribe. I don't prescribe myself. But there's so much crossover with how to do it with someone who is, especially like an alcohol, right? So to me, when I think about, so like RFK Jr., his big thing coming up with deprescribing, right? I don't think it has so much to do with, there's a big argument about addiction versus dependence and all these things. And I don't think the argument is so much about that in the deprescribing world. We're not addicts, we're dependent, blah, blah, blah. That changes how you treat us in deprescribing. I don't think that's what changes how you get treated in deprescribing. I think the medication classification is how you get treated deprescribing, because you would deprescribe someone alcohol very different than heroin or meth, right?
Or steroids.
Or steroids, yes.
For example, they're all, they carry baggage.
Right, and so you have to taper down slowly with steroid use, right? It's not my jam, it's yours, but
It is, but it's interesting. I've had some patients where, trying to slowly do it did not work. What actually worked for deprescribing steroids was, and it sounds kind of weird, but actually to go up a little bit and then down. Do you ever do that in your deprescribing of? No.
So I've heard of like crossing over different classifications and things like that to make it easier depending upon the half-life of the medication and all those things, right? But this is a valid point, because every person is uniquely different when it comes to deprescribing anything.
True.
Right. So, like, for instance, I feel a little shame and guilt that my cold turkey wasn't as terrible as so many people who have been debilitated by their taper plan from their doctor. Right. So It makes me feel terrible that I didn't have to go through all of that. It was bad. But I know people who are on disability because of this. Like, they've had to quit their jobs and things like that. The point is every person is different. So we can't just say, like, look, right now the big push is the Maudsley deprescribing guidelines, which are hyperbolic tapering. We can't just say that this exact framework works the same way for every person all the time. That's how we get into trouble, right? So that's when we forget about the unique differences of every person in deprescribing.
Different genetics, different toxins,
lifestyle, different time of life,
different infections,
yes,
I mean, so many.
All the things, right? Wow. So my makeup is different than your makeup, right? So
I don't wear makeup.
yeah, I did today. Like I normally don't, but I did today for you, Josh. I did. Yeah,
I'm honored.
I know. I know. But yeah, so we are all uniquely different, which means our approach needs to be more individualized. And that's the whole deal with deprescribing is an individualized approach based on the person's need that's sitting before you. And how do you know if your journey off is going to be like mine or if it's going to be like the disabled person? That is part of informed consent because guess what? You don't know. You don't know that you're going to be stuck on this forever and you can't get off of it when you start. Nobody knows because there's no like measurable way to determine that with someone's physiology, right? Maybe some genetic testing, maybe, but I don't think we're that profound in our use of genetic testing yet, but there's no way for any doctor to be like, it's safe, you'll be fine. And most of my patients get off of it okay. I'm like, nah, I hate it.
Actually, I find doing genetic SNPs extremely helpful, but it's not mainstream yet.
Correct. And I don't know that it's mainstream for deprescribing. Like, I mean, I know that there are some genetic SNPs that you can see like how your body uses serotonin or dopamine. That could be important information, research later on to add in there. But I do know, and I don't know a whole lot about genetic testing because right now there's a big push, like do the genetic testing to see what meds you should be on. That's problematic too, because that's not 100% slam dunk.
But it can also help you if you look at some of the CYP, cytochrome P450 enzymes that metabolize different medications. It can help to know if it's fast or slow, et cetera.
Right, or just give you some knowledge about yourself and not always partner it with this med, will work with your genetic code. How about this lifestyle will work better with your genetic code? I like that approach a lot better than the med part. But yeah, I just think that we have a long ways to go in our discovery. It's an exciting time to be here, though, because
totally.
I never thought in my lifetime, I talk with Steve, my husband, all the time about this, and we would commiserate and be like, I just don't think in my lifetime that these conversations that I think about and I have with psychiatric medication will ever be mainstream. And here we are. And I'm like, wow, I'm still living and it's mainstream. So this is great,
It is. And I think it's being pushed by the general public. People were like,
yes,
I want options, just like you wanted options, but you couldn't really find them.
Yeah. Well, and not just for me, but, I've been doing mental health care for 20 some years now. And when you sit and you really pay attention to your clients and the ones who are on medication, I'm grossly generalizing, but the ones who are on medication tend to do the worst. And if you can take a step back from that as a provider, therapist, right? If you can actually look and see like, wow, you're on all the medications, like you're taking them as prescribed and you're doing the things you're supposed to do, but yet you're sitting here coming to therapy telling me how terrible you feel every time you come to therapy. And I just think we need to think critically about that for a second. And that's what started happening to me is I remember one client for sure. And she was probably the one that changed the way that I looked at clients. There's always a pivotal client that you're like, oh, this person. And this was probably 15 years ago. And this person was on a cocktail, right? And would come in and she was getting worse and worse and worse and couldn't sleep and couldn't eat. Then she was diagnosed with anorexia and all this stuff from a benzodiazepine use and all these things. And I just kept thinking, there's got to be something better. There has to be something because, the good steward that I was to psychiatry, I was like, go back to your prescriber, go back. And instead of being curious about maybe the psychiatric interventions are what's causing some of this pain and suffering that you're having, which is like knocking people on their head when you say that, because the thing that's supposed to help you, it's not supposed to hurt you.
Right. And just to be clear, I mean, if someone is having an acute grief reaction or a medical procedure, I've got nothing against them being on a benzo for a few
I've
days.
I've taken a benzo for surgery. I have. But I will say that some people do, if you take one benzo, it will change them forever. So again, do you know that you're that person? No. Right. Like exactly. So but again, that's a risk that nobody talks about when you go in for surgery. It's like, well, it's just one benzo. It's just, Well, sometimes one benzo causes a lot of harm to some people. What do they call it? A paradoxical event. So
True.
it can be So I don't even like to say that flippantly, right? Because you can't get something for nothing. There might be a trade-off here for a lot of things. But I am not against all use of psychiatric medication, and I think people get that wrong about me because I have a very big vocal platform about things, and sometimes it's pretty shocking, but I'm not against it all the time. What I'm against it is overuse and just throwing it at people as a resolution for their life without an off-ramp or without knowing what they could be up against in full. Because again, long-term use of this stuff metabolically can change a person. Short-term metabolically changed me.
Sure.
But it can change your heart, your heart health, your cholesterol, your brain. I think there was a new study that was coming out about SSRIs and dementia and Alzheimer's.
True. In terms of increasing the risk.
Yes, increasing the risk. So, it's a neurotoxin. So, again, you can't get something for nothing. Know the trade-off, though. But that's the whole problem, is that people don't know the trade-off.
Right.
And, so I have a podcast too, Jen, the Gaslit Truth podcast, if anyone is listening. But we started that podcast because Jen and I worked in the same environment years ago. That's how we met. And we started talking on the phone about all the manipulative things that we told people to keep them on their medication. And we said this and we're like, oh my God, we need to do a podcast and start it off just like that. And there's an episode that we called The Dirty 30, and it was 30 manipulative things that we have said to people that we were trained to say to people to keep them medicated compliant, right? And now we look back and we have made amends. We have said we are so sorry, all of these things. But it was the culture of where we worked to say those things. Like, it's no different than a diabetic taking insulin, right? That is the most wrong and manipulative thing I've ever heard. And to tell somebody that just to keep them medication compliant, or, why do you care so much about your sexuality? Don't you care more about your depression? Well, I'm sorry, but when you take someone's pleasure and joy and sexuality away, they're going to be depressed, right?
Right.
But did they even know that could be a trade-off? That's the whole point. Did they know that your sexuality could be forever changed in some cases when they started? Probably not. So anyway, so Jen and I, we like to blow the lid off of, things that and Josh is such a good sport when he's on our show too, because we love the levity that you bring to the show.
Good.
Yes, all the time. You keep us in check. But the biggest deal is we need to start not using manipulative language. We need to view people as if they are capable of understanding the truth of the medication, and so they can make their decisions in a very informed way. Most people aren't making these decisions inpatient. They're not in suicidal crisis, right? And there are some people that are, for sure.
Sure.
But for the majority of people, they're not making these decisions in a crisis situation. They're making these decisions in a 10, 15-minute office visit of a family practitioner doctor or an OBGYN, or in my case, an endocrinologist, right? Sure. So it's not even a psychiatrist, right? So they're making these decisions rapidly and without information. And so then people will be like, well, there's a little insert that you get when you get your prescription at the pharmacy. And I'm like, well, that's kind of too late, isn't it? You've already said yes to the medication. But that little insert, these inserts are usually about 30 to 40 pages long, actually.
Yeah, in very small print.
Yeah, it's probably like 50 to 60 pages long if it wasn't, 8. But the little thing that you get from in your prescription bottle or on the label is not informed consent. No. That is what they have to have on that label. And I think we need to remember that even the 38-page leaflet or insert that you can find online, all your meds are online, are negotiations between the FDA and the drug manufacturer. So they're like what the agreement came up to and said, okay, we have to put these things. We've agreed on these things. There could be way more things that we're just not in agreement.
And if it's egregious or very dangerous, they'll put a black box around it. But
we avoid that black box, though.
Right.
Nothing to see here. All those research things, they were biased, and I'm like, they did it multiple times. They called in experts to redo the research like twice, and then they came up with more warnings after the research was done again. So, I think never in my life would I think like to jump over this black box warning the way that we jump over it. We just don't care about it. But with the rising increase of suicidal and homicidal behavior of our youth, we need to start paying attention to this a little bit more. So
sure. Unfortunately, many members of the youth are getting started on these medications that were initially approved in adults. And see, there's off-label usage of them.
Yes.
And what's interesting, though, is talking about ethics. I mean, in your case, you're spreading the truth about...
I'm trying to.
Trying to, about how you actually were trained to gaslight some of your clients.
Comes from us being quintessential gaslighters, actually.
There you go. But the flip side is just from ethics, you've got these pharmaceutical companies who they answer to their shareholders. Yep. They're trying, and they may have spent $1 billion developing these drugs. So their ethics is we need to return value for our investors.
Right. And it's very interesting when you think about big pharma. Now, I've never worked in big pharma, as a disclaimer to everybody. I know people that have, and it's like sleeping at Holiday Inn Express, right? But I know people that have, and they've enlightened me a lot with the research on, or the lack of research on drug development. And also, it's just curious when someone's marketing budget is way higher than their research and development budget. Like, that speaks volumes. Also, somebody once said to me, they're targeting kids now because moms are fully targeted, right? So moms are targeted, and what's the next best thing? Well, this worked for me. Prozac worked for me, so I think it might work for you too. And so moms being, they also get guilted, right? Like, don't you want to be a good mom? Don't you want to provide the best care for your child? That's a lot of guilt. I was placed in that seat once too. That's a lot of guilt. And so then we bring them in because it's the right thing to do. But again, if you're not making a fully informed decision for your kid and their future, that's a problem. Because again, you're bringing in, I'll just say like a 15-year-old and putting them on an SSRI, Prozac or Zoloft or your sertraline, some people might know it as that, or Lexapro, for instance. And I'm just going to kind of harp on the whole sexual stuff. Like, you might not think that it matters that a 15-year-old might be trading off their sexuality, right?
Right.
But it might matter when they're 18 or going off to college or, that type of thing. Did you know that could be permanent for them? Well, I don't know. I'd rather them be alive. And I'm like, well, that's extreme. That's an extreme thing to say. Most people getting on SSRIs are not on the brink of suicide. They would get more of a benzodiazepine to like calm them down or restrain them if that's where it was at.
Sure.
But an SSRI takes a while to kick in, so to speak, anyway, right? So they're not the people on the brink of that, right? But this is what we've been told, where we're saving lives. And the research just doesn't support that. The research actually might support a very different scenario that we're unwilling to talk about. It is increasing the risk of suicide in that population. The black box warnings, right? So
sure. So we may not be willing to talk about it, but the flip side is where are people getting their information from? Where are many physicians getting their information from? From marketing, from advertising.
Yes, and you would know about that. I remember working for the state. Oh my gosh. So I'm so grateful that I had these experiences because they really frame my thinking now. We would have what was called Farm Fridays. And so the place that I worked at was a prison human services hybrid type situation.
Sure.
It was right next to the county-funded mental hospital inpatient, right? So these pharmaceutical reps would come in on, I think it was one Friday a month or whatever, and they would bring this smorgasbord of food, we weren't prescribers, but we were the right-hand man of prescribers. Like we were the eyes on the people all the time. We just went for all the food, really. But they had all their booths set up, and they were very cordial and jovial. And, you know, this is the next thing. And what should we watch for? Oh, this or that. But this is way better than this drug over here used to be. And all this stuff. Back then, I didn't even realize what was happening, right? I was just there for the free food, you know. It was really good most of the time, but the influence there, right? So then even just me being influenced, I wouldn't recommend a certain medication, but I would recommend I talk to the shrinks about it, right? Or my home life, right? Well, I heard the farm rep said this thing might be good, right? So it trickles into your home life as well when you're influenced that way by marketing.
Right. Some of it's subconscious, etc. These are people I trust.
Yeah.
Well, let's change gears here a little bit and talk about, you've written a couple books. You wrote
just one.
Didn't you write one about heels, taking your heels off?
That was the that was the originating book.
And you're not even wearing heels now, so you're
I don't wear heels.
Yeah.
The heels I had in there, so it's funny because if you ever see pictures of me with these heels, they're obnoxious heels. They're the heels that I walked with when I got my PhD. I wanted them to be the most obnoxious things ever, and they were. And so now I just take pictures with them because I will not wear them. I'll break my ankles to bits. But anyway, so yeah, it started off with, it was called Kick Off Your Damn Heels, was the originating book. And that was started probably a year or so, maybe more, before COVID happened. And it wasn't speaking to me anymore. And so I set it down and thought, I'm never going to write this book. I'm never going to do it. I didn't like it. I didn't like how it was coming out. And now I realize that that's because that book wasn't meant to be written like that. So I think it was a year ago, I finally published the book, and it's called Your Best Brain. And, I have it right here. Here you go. Whoop. Your Best Brain. Oh, wait, it's right back there, too. It's called Your Best Brain. And really what it outlines is the 5 pillars of good mental well-being. So nutrition.
Wait. So these pillars don't involve pills?
No,
I was just checking.
Actually, what's intertwined in this book is actually my story as well. So every chapter of the book is another layer of my personal story with psychiatric medications. So you'll read a little bit more about me, and then it'll go into the chapter. So it's nutrition, sleep, movement, and meditation is in the book. Meditation, mindset, stress management. So that's the book. And so we've called this book too, like it's like the 3-month warm up to deprescribing. So these are the things that you need to have in place before you decide to get off your psychiatric medication. Get them good. And I say get them at a 70% rate. It doesn't have to be 100, but get this down at about a 70%, then go into deprescribing, but continue working with these things because, you know, we found that a lot of times people, when they get on a psychiatric medication, it's a solution to a problem, right? It's something that was going on in their life or that they've dealt with for a while. They get medicated, and then that's just where it sits, right? They don't get more work on it. They don't change their life because they don't have to. I'm air quoting, they don't have to at the time. When you get off the psychiatric medication, it's kind of like time jumps backward. Like you suddenly go back to that traumatic time that you didn't deal with, and here it is. You go back with, like, my nutrition was crap, so I need to build the foundational things. But guess what? It was crap then too, right? Maybe that was the origination of some of your problem, is that your sleep was bad and your nutrition was not foundational. And so now you're faced with having to do all of that work again, right? Or to face it again, which is a lot. It can be overwhelming for people.
Right, if they're certainly trying to do it by themselves.
Yes, exactly.
Wow.
That's why I think support is great. And there's a lot of people out there that are doing taper coaching and things like that. What they're missing is the psychology behind all the tapering. And that's where, you know, I come in, is we can address those things in particular while you're tapering.
Wow. And I'm thinking to some of my patients with dementia happen to be on
the elderly.
Some of the medications we're talking about, basically to decrease the electricity in their brain, which
I would do that, I guess.
Yeah, I mean, if you're anxious and you need something, so
it flattens you like this, like it'll flatten you like a pancake.
Exactly, and unfortunately, it's been some of these have been associated with increased risk of dementia. And I've also seen some patients, if I'm able to wean them off,
Yep.
their cognition improves.
It's amazing what happens when you're no longer flatlined, right? It's amazing. And, I mean, I guess that's probably the best part about me having had a personal experience for 6 years is I understand what that flatness feels like. You just don't feel like yourself. And some people experience what's called anhedonia, which is like a even deeper level of flat, like not being able to access emotion. When you look at them in their face, like they literally look void, when they have anhedonia. And this all happens because of psychiatric medication, or a fast taper does that too. A fast taper can cause akathisia, which is like this horrific internal restlessness. Think about restless leg on crack, like seriously. But that's where a lot of people end up taking their lives, is when they're experiencing that akathisia, because it's literally like coming out of their skin. I don't know if you've ever. I experienced akathisia once because I was on too much thyroid med.
Oh, interesting.
Yeah. So and I was like, oh my God, is this what akathisia feels like? Like on some level, right? It was, but at least it subsided for me. But for some people, it takes a long, long time.
Right. So fortunately, I've never experienced it myself, but having worked in emergency rooms for 20 years,
you could see it.
I've seen too many cases.
Yeah, and it's scary for them, and it's scary for the people around them because you don't know how to help them, right? And that is definitely not a psychological thing, right? It's a neurological injury. So, yeah.
True.
So this is like, there's so much to account for in long-term use, again, in brain health, period, right? If you want a healthy brain, like reduce your toxic load, like reduce these things. But if you're on psychiatric medication, like this is to manage expectations for people. And sometimes people say, they're like, oh man, that just gave me lost hope when you said this. And I'm like, but you got to manage your expectations on how long it might take you. I say might, right? My rule of thumb is 1 to 3 months for every year you've been on something. So if you've been on something for 20 years, right, you're looking at minimum 20 months.
Oh, wow. Okay.
Or 4 years, And I say the 1 to 3 because life happens along the way that you might have to slow down, stop. You wouldn't want to do this over the holidays probably, So I give the 1 to 3 months as like you got some buffer here for life to happen. But as long as you're setting the course and you're doing it safely and slowly, that's what we're looking for, right? Slow and steady does win the race. If you go fast, you can cause more neurological injury.
So I'm curious, obviously you do deprescribing one-on-one. Do you ever take groups through this? Because it's so common.
I've thought about it, but it's not something that I think too deeply on, because I really I appreciate the individual experience with people. I think we could miss some of that if we do it in a group. But but there are free support groups out there for people that are deprescribing. If you go to the Antidepressant Coalition for Education, ACE, they have free support groups for people that you can just hop in, which I think is a wonderful resource, just as a supportive thing to know that you're not alone. Because I know so many people think that they have to go this alone, and they just don't. Yeah.
Wow. And one of the things, what are your thoughts on amino acids? Do you ever recommend amino acids for your clients?
There's a whole section in my book on amino acids and nutrition.
So tell us more.
Okay, so I want to preface this with amino acids aren't for everyone.
Right.
Okay. So, and again, do you know you're going to be the person that it's not for? We don't know. Whatever. But I was originally trained in amino acid therapy, and that is what I started with. Early days of Google, when I'm sitting in front of the one patient that I was talking about, and I started Googling, how can I support dopamine in the brain naturally, right? And I came up with tyrosine, right? I had no idea. So again, I've been a therapist all these years. I had no idea how to influence the brain, because our job was to talk your way through problems, not support it in any other way.
Right.
So bizarre. Anyway, so I was Google searching how to do this, and I happened to come across a company that was like specializing in this, and I'm like, you're the one for me. And so I started with amino acids, but you have to be careful because, let's say you're taking an SSRI, which is increases the serotonin in the synaptic gap, and you use like 5-HTP or tryptophan, like you could have serotonin syndrome. I haven't found it to be that way, but some people have serotonin syndrome just from being on the meds, period. Sure. So, you just have to know what you're looking for and watching for. But I love amino acids. I think they're great. I think they're great for the average person too, just to take. And if you're having a slumpy 2 p.m. day, a little tyrosine could be very beneficial for you, right? Instead of caffeine,
Right.
So.
But everyone has unique biochemistry,
Yes.
There's more than one pathway for these amino acids.
100%. It can be complicated, right? But I've joked around and said bodybuilders have known about this stuff for a long time. Like, I always feel like the bodybuilding community is ahead of everybody else in how to enhance their performance.
But unfortunately, if you look at bodybuilders as a group, their life expectancy is not good. They're
when you're talking about, shooting yourself up with hormones and stuff, of course, yes, I get it.
Right.
But they've been using amino acids in the gym for a very long time. So, and I just think there's something to that. Not that I want anybody to be a bodybuilder and do it in an extreme way, but yeah. Sure. So I do like amino acids, and I like foundational things too, just like a multivitamin or omega-3 fatty acids. And I think if we can build our foundations, our brains will be better if we have that foundational piece down. And it doesn't take a lot. Like, I say this out loud, but if you were to look in my cabinet, I've got a lot of supplements in there because I try them all out, right? I'm like, oh, I've got all these supplements. But honestly, for me, I just take a couple every day to keep my foundation going. So
you use the word foundation. Mm-hmm. My understanding is some of your understanding of this whole field was through the lens of omega-3s. Is that right?
Oh, yes. Yeah.
So tell us that
Okay. So this was early in my career. I was still working for the state in a prison situation. And there was, we would sit around with all the disciplines and do treatment planning. And I was a therapist there too. And there was an inmate in particular that was extremely aggressive. Like, they couldn't get him out of segregation because he would always fight. And so that's what we were care planning, is this aggressive inmate. And I had brought in to the care plan meeting a research article that was done in a jail. Okay, so that close, very similar environment, inmates who were aggressive, couldn't get out of segregation in the jail, and they gave them omega-3 fatty acids. And suddenly their aggression started ticking down. And I was like, I have got the holy grail idea here. And so I put it on the copy machine and I brought it all in, and I was like, I've solved this problem single-handedly.
Right.
And I'm handing it all out when it was my turn. And I'm like, listen, this research about omega-3 fatty acids, blah, 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 reducing aggression, and I think we should try it out. And the psychiatrist to my right, I'll never forget this, looked at me and said, you're not a dietitian. This is out of your lane. And I went, got it all back up, put it all away, put my tears in my face. And I went to my office and I bawled my head off because I was like, and then that's when I realized also how siloed disciplines are, even in a multidisciplinary meeting. We're not thinking about other things or exploring other disciplines in those meetings. We're just exploring our own. And I really feel like that probably could have helped that person a lot if we would have thought about it. But then again, it's kind of like an IEP in school. If you bring up omega-3 fatty acids in an IEP in school, then the school is required to provide omega-3 fatty acids. So same thing in the prison. Then the prison would be required to somehow provide omega-3 fatty acids to this person if we put it in their treatment plan. I understand that now. I don't think it's right that we still can't do it. But I feel like that was one of my biggest entrances into looking at this differently from a brain health perspective. And I literally set it down, and it was years later that I picked up all that information again. And keep in mind, again, just like psychopharmacology, I had to go back to nutrition school. So I went back to nutrition school, and then I did functional medicine training. Like, there's just not enough time in the day for me to get enough training in my brain because it's constantly changing. And I just want to be as in the forefront as I possibly can, despite only being a therapist,
Right. And what we know now, for example, not only all omega-3s are the same.
Right.
If you happen to have one that's rancid, that's
Right.
or has high levels of heavy metals like mercury,
Yeah.
or
Or if they're 2
yeah,
for 1 at
yeah,
Costco, don't buy them. There's a reason that they're 2 for 1 at Costco. Like,
right,
high quality omega-3 fatty acids will do wonders for a person, but it's important to get that high quality version. This is where people want to cheap out, I think, because
sure,
they can be very expensive, in all honesty, to get a really good product. But I did, this was a long time ago. I did a TikTok and I compared omega-3 fatty acids on a shelf. Like, I think we were in Costco or Sam's Club or something.
okay,
And I did this comparison, and I did a calculation, like, because I was looking at like 1,500 milligrams of the EPA DHA, right?
sure,
And so I turned to all the labels around and did the calculations and how many of these you'd have to take to hit 1,500,
sure.
right? And one of them was like 12. And I'm like,
Whoa.
no wonder they're 2 for 1. Like,
Yeah.
this is 3 servings in this bottle. It was nuts because,
Right.
but if you get a higher quality one, it's like 2, 1 or 2. So, but yeah, you really have to kind of be smart about it and do your calculation, know what you're looking for, know what kind of fish you're getting from that so that it is lower mercury.
All right. I push for algae, which is much lower on the food chain, much lower levels of heavy metals.
Right. And for people who
plastics,
are vegan or
pesticides.
vegetarian, that's a great option because people who are vegan and vegetarian, I'm not, don't get a lot of omega-3 fatty acids. So the seaweed version is a good option for them too.
Yeah. So the other thing is, whichever type of omega-3 you have, you should keep it refrigerated, so it's less likely to get rancid. But if you go to the store, most of the time
Just on the shelf.
they're and who knows how long
Exactly.
they've been sitting there.
Exact. Well, if they're 2 for 1 at Costco, I think they're flying off the shelves at that point. But
Yeah.
yes, yeah. So they are sitting on the shelf, and they're not in climate controlled in any way. So yeah, I get them directly from the manufacturer. So, and they usually come in an ice pack for me. So yeah,
Wow.
but I would recommend anybody do that. Yeah.
Wow. So we've covered so many different
fun.
angles. It's been fun. If you could, from your book, you mentioned the different pillars, I guess.
Yeah.
What are some tips from those pillars that you can give our listeners?
So the easiest, if someone wants a place to start, right? The easiest place, I shouldn't say easiest, but it might be. The easiest place to start would be to stabilize your blood sugar. One simplistic starting point is to eat more protein more frequently. And not only are you going to stabilize your blood sugar, but you're going to be fueling those neurotransmitters that you have as well. So to me, when I see somebody struggling, it's really hard when you have depression or even anxiety to get a grip on your nutrition. Really, really challenging. And so when I start with something very small like that, like just focus a little bit more today on eating more protein, you would be surprised how much better they feel just by doing that. Also, eating protein before bed sometimes will stabilize your blood sugar at night and help you sleep deeper instead of, having a bowl of ice cream or, a complex carbohydrate before bed. So if you struggle with waking up too early or waking up a lot during the middle of the night, that's likely a blood sugar problem that a little bit of protein can help solve.
And I'm curious, in your practice, do you see many seniors or people with
Oh my gosh.
dementia, things like that?
Not with dementia.
Okay.
Well, it's funny because the more medicated they become, the more they look like dementia.
Sure.
But I'm seeing more people age 60 plus wanting to get off of psychiatric medication that they've been on for a long time, likely because there's so much more information out there about Alzheimer's and dementia. It's
Right.
freaking people out. And they're finally to a point where they're like, I want to save my brain. I don't want to be in a nursing home because of this.
course.
If it's preventable, I want to prevent it. And I'm like, you go, like, let's do it. Yeah. Because I mean, as we were talking before, the elderly and aging population is like the most medicated, psychiatrically medicated population. And I hope that at least our generation is going to start changing that, right?
I hope so. I mean, and typically I might have a senior on a dozen different medications.
Yeah, I know. And yeah, my poor mother, I always bring her up in podcasts. She's one of them, and I always tell her, I'm like, Mom, you got to get off some of that stuff. You got to get off. I'm trying. It's hard for her too. So I think just be mindful when you add something, maybe look at subtracting something else. Don't just keep adding and adding and adding. That's why, the elderly, they end up getting a drawer full of medications all around, right? Like, so pretty soon you're just being propped up by a pill bottle, But, just think about that. Like, if I need this pill, what could I adjust in my lifestyle that maybe I could avoid taking this pill? Or is there a pill that I can remove before I add something new? Just be a little more curious about those additions and subtractions.
Wow. Is there any new technology that you're optimistic about in this area?
Do you know the new technology? I don't even know if it's new, but I am really curious about how hyperbaric oxygen therapy might play a role in mental well-being, number one, and deprescribing. I don't know. There's no research. I'm like, please, somebody help me with the research on this, because I would really love to do a study on it and see how, if there's any, points of interest just by using hyperbaric oxygen therapy.
It's powerful, and in terms of research, at least in the dementia or Alzheimer's space, many of the studies do 40 sessions.
Yeah.
But what's challenging about hyperbaric oxygen is there are two variables. It's the amount of pressure and the amount of oxygen.
Yeah.
So there's so many, you can't just say, oh, everyone gets this.
Right. Well, again, that's that individuality, right? Based on their needs. But yeah, I that's what I'm excited about. And I think it's getting more popular. So I'm just excited to see it grow. But I do know a lot of people get the chambers at home. Like, that's a new thing too.
Sure.
But then I get curious about, that individuality. Do they really know what they're doing for themselves, right? Like, could it be harmful? And it can be for some people.
Oh, yeah. In the example, what hyperbaric oxygen does is it improves the function of mitochondria, which produces energy and removes toxins for the brain and other cells. Unfortunately, if you have someone with high levels of toxins or infections, you could actually bust this biological film, this glue that has all those negative things, and you can actually make someone worse.
Yeah, that's that's with everything. Like,
True.
Again, like, too much is too much, and you might not be a person that needs it. And so how do you know? You don't.
Right.
You don't. But yeah, I really think that there could be something to that for our deprescribing folks out there. But yeah, there's no research yet, but it's promising.
Wow. What would you say are the three most important points we've covered?
Regain your sense of personal agency. Ask a lot of questions. And don't be afraid to ask questions when you're being prescribed something. Demand, but not in a bad way, full informed consent, right? And work on the foundational pieces of your health before you start medication. Or if you start medication, work on it now. Like, don't set it aside. Work on those foundational pieces.
And Dr. Teralyn, where can people find you?
Oh, well, you can find me on social media everywhere, especially TikTok. I don't know why that happened, but anyway, it did. Or just go to drteralyn.com.
Wow. I salute you. Thank you so much for being willing to come onto my podcast.
Absolutely.
And, this has been a really important episode because we've talked specifically about how your brain can be injured by some of these chronic medications, whether it's narcotics or benzodiazepines or SSRIs, etc. And, it's just amazing that someone like Dr. Teralyn has focused on deprescribing. And with that, I want to thank the viewers for watching today. If you like this format in person, please leave some comments. And if you found this episode helpful, please share it with just one person who you think would benefit for it too. So this has been Dr. Josh with Alzheimer's Breakthrough. Peace and plants.